In a sleeve gastrectomy, we take around 3/4 of stomach out, and this is pretty much done through the keyhole or laparoscopic surgery or minimal invasive surgery. Before the surgery, you will have initial consultation, followed by the assessment by the dietitian and the bariatric nurse. You will have a pre-operative assessment, and on the day of surgery, you will see me for consenting. You will see the anesthetist, and the procedure is done under general anesthetic. You will have 5 small cuts in the abdominal wall, and we excise the thin or part of the stomach. Around 3/4 of the stomach is taken out. Pretty much we have done everything laparoscopically, and we have never had to convert to it an open operation. Like any surgery, there is risk of bleeding, infection, or leak from the staple line. But to reduce the incidence of staple line leak, we not only use the staple with 3 rows of staples on either side, but we also add a reinforcement called seam guard on top of the staple line, which is the site of leak. In addition, I put a tissue spray or a glue to reduce any leak rate there. During surgery, we also check that the integrity of the staple is intact by a methylene blue test. You will have a tube through the mouth to the stomach, where you put some blue dye by the anesthetist, and you check the integrity of the staple line. And the resected stomach, which is sort of 70 to 75% stomach, is taken out, and you will have subcuticular stitches and glue. So there are not any significant scars left in the wound. Usually the procedure will take around 40 to 45 minutes. Obviously it depends on the body mass index. The higher the body mass index, it may take longer. Also intraoperatively, if you got a large massive liver or previous surgery, it may take a little longer. Like any surgery, risk of bleeding, infection, leak, or any other visceral injury. But in our hands, the risk is very, very small. Following surgery, you will be closely monitored by our team in the ward, and they monitor your pulse, blood pressure, pain score. They give any medication required for nausea and vomiting, which may occur following surgery, and the pain control. Once your observations are stable, you are comfortable, you are tolerating fluids, we will love you to walk short bursts, sit up, and nice breathing, and we will keep you overnight. Just make sure that there's no concern, and the next day we will encourage you to drink more free fluids and do the state test, which is done by a physiotherapist. So once you're comfortable, minimal pain, no concerns by the staff, by me, and you're happy to go home to your bed, we will let you go with a clear advice on the medications to take home, and we also give injection to prevent any deep vein thrombosis or pulmonary embolism. We will take the measures for DVT prophylaxis, and the advice is to go home to take liquids for 2 to 3 weeks, semi-solid 2 to 3 weeks, and the solids after 4 to 6 weeks. And normally we follow you in 6 weeks' time. We send the specimen of the resected stomach to the lab just to make sure that there is no concern in the resected stomach. And it is expected that as the time goes, you recover. Most people, by the time I see, in 6 weeks, will lose around 1.5 to 3 to 4 stones, depending on the initial BMI. And you will be periodically followed by me, my pediatric nurses, and the dietitian. And it is expected that you will lose 60 to 70% excess weight, or a quarter to third of your weight. Once you start eating solids, you start with fish and chicken. Try to avoid the steak and bread. We encourage you to drink plenty of water, which may be a little tricky sometimes. And you need to take the supplements like the multivitamin, calcium, which is calcium and vitamin D, B12 injections 3 monthly, and iron.